introduction, and it's a great honor to be here among everyone today. I have no disclosures for this presentation. Here is the outline of my presentation today. So after a brief background overview, I will review the current guidelines on coronary revascularization, and then I will present some of the evidence to support these guidelines, after which I will review some differences between the STEMI versus non-STEMI population. And lastly, we will talk about bleeding risk considerations. Acute myocardial infarction is among the leading causes of mortalities in developed nations. And preferred treatment options for acute MI have markedly evolved over the past 50 years, whether in the fields of pharmacotherapeutics, catheter-based, or surgical management. In some cases of acute MI, emergent surgical revascularization is warranted. For example, in STEMI patients with ongoing hemodynamic instability or with refractory ischemia, and in cases of acute mechanical complications. However, in most cases, the optimal timing of surgery is less evident. When surgery is done too early, CABG has been associated with injury from reperfusion, systemic inflammation, and with high bleeding risk. But on the other hand, delayed surgery may put the patient at risk for recurrent ischemia with the potential of worsening left ventricular function and mechanical complications. So we will review the current evidence to guide decision-making with regards of timing of surgical revascularization in patients with acute MI. As I said, I will start with a quick review of guidelines for revascularization in context of ACS. And for the sake of brevity, I will focus on guidelines for surgical revascularization primarily. And I will also review guidelines pertaining to the timing of intervention. The most recent American guidelines on the management of acute STEMI patients assigns a Class 1 recommendation for primary PCI in patients with ischemic symptoms for less than 12 hours, and this is to improve survival. With regards to recommendations for revascularization of the infarct artery in STEMI patients, there is a Class 1 recommendation for PCI or CABG when PCI is not feasible in patients who have cardiogenic shock and hemodynamic instability, irrespective of the time delay from MI onset. Furthermore, CABG is recommended as a Class 1 recommendation for patients with STEMI who have mechanical complications. As well, there is a Class 2A recommendation for CABG patients with STEMI in whom PCI is not feasible or successful in cases where there is a large area of myocardium at risk. Lastly, emergency CABG is not recommended after failed PCI when there is absence of ongoing ischemia or large area of myocardium at risk, or if surgical revascularization is not feasible due to no reflow or poor distal targets. With regards to revascularization of the non-infarct artery in patients with STEMI, there is a Class 2A recommendation for elective CABG to reduce the overall future risk of cardiac events. The European Society of Cardiology also published some guidelines more recently in 2023 for the management of ACS. And in these guidelines, there is a Class 1 recommendation for emergency CABG in patients with ACS-related cardiogenic shock if the PCI of the infarct-related artery is not feasible or successful. There is as well a Class 2A recommendation for CABG in the context of an occluded infarct-related artery, when when primary PCI is not feasible or successful, and when there is a large area of myocardium at risk. Lastly, revascularization strategy should be based on the patient's clinical status and comorbidities, as well as on their disease complexity. Interestingly, both the 2021 American and the 2023 European guidelines did not mention optimal timing for subsequent surgical revascularization in patients who undergo primary PCI for ACS. So what should we do in these cases? I will try to answer this question today by reviewing some of the limited evidence on the topic, starting with a recent systematic review and meta-analysis published by Lang and colleagues in 2022. This study analyzed 19 other studies with a total of 114,000 patients with acute myocardial infarction who underwent staged CABG. Included studies assessed mortality or major adverse cardiac and cerebrovascular events as a function of timing of surgery. The authors defined early surgery as CABG performed within 24 to 48 hours of acute MI, and late surgery was defined as surgery anytime after 48 hours of ACS presentation. In-hospital mortality was significantly higher in patients who underwent CABG less than 24 hours after ACS compared to those who had surgery more than 24 hours after ACS, with an odds ratio of 2.65, which was statistically significant. Similarly, patients who underwent CABG less than 48 hours after presentation had a significantly higher in-hospital mortality than those who underwent delayed CABG after 48 hours, once again with an odds ratio of 1.91, which was statistically significant. There was no difference between early and late CABG with regards to perioperative MI and cerebrovascular incidence. Most recently, in March of last year, 2023, Bernard and colleagues performed a large single-center retrospective cohort study to evaluate the impact of timing of surgical revascularization on mortality, and their cohort included 477 patients who were stable after myocardial infarction. The overall 30-day mortality of the cohort was 7%, and it was significantly higher in patients who underwent surgery within 4 days of initial presentation, with a 30-day mortality of 14%. Risk factors for mortality in this study included older age, peripheral vascular disease, preoperative renal failure, and preoperative ischemic recurrence. However, LV function, type of acute MI, and perioperative transfusions were not linked with mortality. So these findings suggest that early revascularization may be detrimental to patients who have non-cardiac comorbidities, which confers them a baseline higher surgical risk. A large cohort study from Maganti and colleagues and a national retrospective study from Klemfelter and colleagues also demonstrated similar results with regards to the benefit of delaying surgical revascularization, particularly in high-risk patients. This is consistent with the findings from a study from Lemaire and colleagues, in which patients who underwent surgical revascularization within 24 hours were more likely to develop cardiac, renal, respiratory, and bleeding complications. However, most of the literature on the topic of optimal timing of surgical revascularization in acute MI was derived from non-randomized data, and therefore the burden of selection bias and confounding by indication in these cohorts is very high. So in other words, patients who required surgical intervention earlier were more likely to have a higher extent of ischemia and to have hemodynamic instability than those who could tolerate and survive a preoperative waiting phase of a few days. Nonetheless, there seems to be overall a U-shaped distribution in mortality depending on the timing of surgery from acute MI presentation. And this figure is adapted from a manuscript from Chen and colleagues from 2014. So the U-shaped concept supports the idea that the lowest mortality can be achieved after the hyperacute phase of systemic inflammation and before the development of irreversible complications from myocardial injury. I will now review some data comparing the differences between STEMI and non-STEMI patients. As we know, the clinical course and treatment strategies of STEMI versus non-STEMI are often very distinct, and this may influence the optimal timing for surgery. For example, the transmural infarction seen in STEMI results in a marked increase in inflammatory markers such as CRP, and compounded with the inflammatory response of CABG itself. This can lead to a systemic inflammatory response syndrome, which is a well-known risk factor for perioperative mortality. Back to the systematic review that I presented by Lang and colleagues looking at acute MI in patients undergoing CABG. There was a significant mortality benefit in delaying surgery by at least 24 hours in studies that looked at STEMI and non-STEMI patients, and in study that looked at STEMI patients only. However, as you can see in red, early versus late timing of CABG did not significantly impact mortality in patients who had non-STEMIs. So there may therefore be a benefit to delay surgery in STEMI patients, but not as much in non-STEMI patients. I will now briefly touch about the bleeding risk considerations. So in ACS, anticoagulation and antiplatelet therapy, and sometimes fibrinolytic therapy, is a vital mainstay of management. While significantly decreasing the risk of ischemic recurrence, these agents increase the surgical risk due to bleeding. Patients with coagulopathy and prolonged bleeding times suffer from longer surgical times, higher transfusion rates, and higher risk of re-exploration. In the 2017 European Society of Cardiology update on dual antiplatelet therapy and coronary disease, and in the 2018 Canadian Cardiovascular Society guidelines for the use of antiplatelet therapy, there is a specific timeline for guiding discontinuation of antiplatelet therapy prior to CABG, as shown in this adapted table here. The European guidelines support this timeline recommendation as a class 2 recommendation, and the Canadian guidelines assign it a strong recommendation. However, interestingly, in the American guidelines, there is no mention of recommendation for timing of discontinuation of antiplatelet agents. This information on this slide is very paramount to be considered when deciding on optimal timing for surgery in ACS patients. to balance the risk and benefit ratio of increased surgical bleeding risk, for example. So in patients with ACS who require CABG after receiving antiplatelet agents, there are a few strategies that we can use to mitigate the bleeding risk. For example, when possible, off-pump surgery may help avoid some deleterious effects of the cardiopulmonary bypass on hemostasis. As well, we can perform platelet function testing, such as rotational thromboelastometry assays and genotyping assays, which can guide decision-making with regard to timing and with regards to de-escalation of antiplatelet therapy. As well, there are some antiplatelet reversal agents that are currently being investigated for clinical use. For example, with the REVERSE-IT trial, which is a multi-center, open-label, single-arm prospective study evaluating bentrasimab, which is a monoclonal antibody targeting ticagrelor. This trial will be performed on patients who present with major uncontrolled or life-threatening bleeding, and in patients who require urgent surgery who did receive ticagrelor. To conclude, while some studies, have shown an association between early CABG and surgical mortality following ACS treated with primary PCI, the optimal timing of CABG remains to be elucidated. There seems to be a benefit in delaying surgery by 48 hours after initial ACS presentation. However, there is paucity of data on the additional value of further postponing surgery, for example, delaying it by a few weeks. Ultimately, the decision for optimal timing for each individual patient should be performed by a multidisciplinary heart team and should be individualized to each patient's risk profile. We need higher quality studies with ideally randomized treatment allocation with regards to timing of surgical revascularization to better know what is the best practice following primary PCI in ACS. Thank you so much for your attention, and I would be happy to take some comments or questions on this topic.